Good afternoon or good evening, everybody. Wonderful to have this webinar tonight. My name is Thomas Jansen. I will be the moderator of this webinar tonight. Okay, this webinar on sexual functioning in men with spinal cord injury is a joint webinar organized by the International Functional Electrical Stimulation Society, as you can see. This is a collaboration, and the mission of the international of this group is to promote the research and application and understanding of electrical stimulation technologies in rehabilitation and medicine. We have a very nice website, and you can please have a look at it. And the other partner in this webinar is the Spinal Injuries Association. It's the largest, or one of the largest, charity groups in the United Kingdom for SCI. Please, Damian, you can maybe talk a little bit more about it. You know about it. Yes, this is one webinar in a series of webinars. We, as IFES, we try to organize on a regular basis these webinars, and this time we do it in collaboration with SCI. And tonight it is on the sexual functioning for men following spinal cord injury, current treatments and recent research. We have 3 presenters, and I will introduce them later in a little more detail, but we have Damian Smith, Neil Marshall, and Damian Street. Okay, so like I said, it is the topic of this webinar is sexual functioning for men following spinal cord injuries, current treatments and recent research. I would like to introduce a little bit the topic of tonight. When I talk to my students about spinal cord injury, they're human movement scientist students, so they don't know anything about spinal cord injury. I always show them this slide. And I ask them, what is a spinal cord injury? What are the problems? And they say, well, paralyzed muscles, they're in wheelchairs. And then I tell them, ask them, okay, that is pretty clear, pretty obvious, but what else? And then they become silent, and I wait a while and I say, well, you got the idea, right? This is an iceberg. So what are the other problems? And well, they don't know. And I start talking, and I said they have a few more problems, or they can have like cardiac innervation problems, sensory deficits, temperature regulation, urinary tract infections, and the list goes on. And then I say, well, it's probably not everybody with a spinal cord injury has all these problems, but definitely every person with a spinal cord injury has some of these problems. And altogether, they're very important and determine the quality of life of individuals with spinal cord injury. Rehabilitation and life after rehabilitation is not only about the paralyzed muscles, but it's about all the other problems as well. And a very important aspect of these problems are sexual problems. And not a lot of people outside the rehabilitation area think about sexual problems or bowel problems or incontinence, but they are very important for the quality of life of people with spinal cord injury. So I'm very happy that we will discuss some of this tonight. Unfortunately, that is not my area of expertise. I'm more like an exercise physiologist, but luckily we have a great lineup of speakers who know everything about this topic. We have Damian Street. She will talk about a survey that she worked on. After that, we will have Damian Smith on current treatments for sexual functioning. Damian will continue then with some research, a research study on abdominal electrical stimulation and sexual functioning. And Neil Marshall will talk about his research project on the perineal electrical stimulation. Afterwards, we will have, there's plenty of time for questions. If you want ask a question, you can use the Q&A button to post your question. You can write them down. It is anonymous. So please post your question in there, and we will try to answer those questions after the talks. Also, after each talk there, if you want to have a specific question on this topic, you can just ask immediately. But we're going to start now with Damian. So maybe you can put on your slides again, Damian. Damian is an NIH NHS Research Fellow at the Salisbury NEH Foundation Trust. She has a background in neurorehabilitation, and among her research interests are using electrical stimulation for neurorehabilitation, bowel and bladder function, and sexual function and respiratory function. And she is also a board member of IFES. And next to that, she's a good friend of mine. So please, Tamsin, the floor is yours.
Thank you very much, Thomas, for that lovely introduction. So the background to doing this information webinar came from doing a survey with the Spinal Injuries Association on sexual functioning. Originally, we did the survey because we wanted to understand more about what the research needs were for in this area. And the survey findings led to the development of this information webinar, and we were somewhat surprised by some of the findings, but some of the things we were expecting to see. So I'll just get right into them. So we had 176 people who responded to the survey. In terms of the time of injury, we had a really good spread in terms of when people had had their injury, but we did have a good representation from people who'd had their injury more recently. So in the last sort of 10 to 15 sort of years, which I would say would be sort of representative of what we would see in current diet practice. So I would argue that we do have some good representation of what people might be experiencing currently at the moment. In terms of the age range, we had a widespread of ages, with most people being in the 55 to 64 year bracket. In terms of injury level, we had around 100 people with an incomplete injury responding, and then I think it was 59 people with a complete injury, and then 17 didn't know or weren't sure of the injury level. The most frequent people responding had an injury level of C5, C6, C4, but then again, we also had a pretty good spread across different levels. So the question which really led to this information event was this question about people feeling informed of the choices and treatment or medication for sexual functioning that they had. And we were surprised somewhat to see that a lot of people didn't feel informed at all about what choices that they did have and what treatments were available. And this is why Damian is going to talk about a little bit later on about the current treatments that are actually available, a really important question. Other questions we asked about the level of sexual activity with a partner or masturbation prior and after injury. And prior to injury, people reported being regularly active, and after injury, there was more of a tendency to be not active at all, or indeed less active. This could be due to a little bit influenced by life stage and time carrying on, but certainly this is something to look at. The satisfaction with level of sexual activity, again, stood out. A large number of people reported not being satisfied at all. We didn't have sort of, I guess, data from talking to people who didn't have a spinal cord injury to check this level, but there certainly seems to be room for improvement and for providing available treatments and indeed further research in this area. An interesting one was the most important factor for sexual functioning. So this is really important in terms of further research areas that you want to explore. What is actually important to people in terms of their sexual functioning? What things do they value? So we want to concentrate on things that are going to be supportive and be useful to people. So the top one was being close and intimate with someone else. And then the second one was orgasm, feeling arousal and pleasure, but partner satisfaction also was quite high up there. So this is important to take into account. A lot of research that is available has tended to focus more on the sort of the physical attributes that can be readily, something can sort of be sorted out with, and you know, something that you can do with maybe a pill or some sort of medication, but taking into account things that are a little bit harder to measure, like orgasm, feeling pleasure and arousal, maybe a little bit more difficult to measure, and something that's maybe been a little bit more neglected in the research literature. Again, something else really important to us in terms of further research is identifying the issues which are going to affect people's sexual functioning who've had a spinal cord injury. And erectile dysfunction featured quite highly as an issue. And other areas were reduced sensation, and something that came out also was bowel and bladder issues. So some of these, Damian will be talking a little bit about how it's possible to manage some of these issues that have been risen. Some of them we do have an understanding of how we can manage them, but others, again, we probably need to think a lot more about in terms of further research in this area to provide support for those areas. Okay. In terms of the effectiveness of treatment attempted for sexual functioning, medication, unsurprisingly, was something that featured quite highly. And people found, although that was the thing that they were maybe using the most frequently, that it was only partly effective. So definitely room for further improvement there. And sex devices also were only found to be partly effective. So definitely room for more improvement there. In terms of the type of medication that people are using, this is as we would expect, Viagra, Cialis, Citalopram. This was also again found to be partly effective. And a lot of people were not taking medication and not finding it effective. Okay. And then I guess a sort of a similar picture for sexual functioning devices. The most common thing that people were using, so manual stimulation, vibrator or massager, again, only partly effective. And a lot of people were not using ASA devices, not finding them effective. This one was a little bit more interesting in terms of probably the treatment and care that people were receiving, maybe during their rehabilitation, whichever pathway they were taking. And the reason for not receiving treatment for sexual functioning, the biggest thing that came out was I was not aware that these were treatment options, which is a little bit concerning that people weren't aware of the treatment options that are available. So something that we're going to do today is just talk about some of those treatment options that are available for people, and also provide a contact details for people to find out more about this in their own time as well, and talk on an individual case for themselves for their current situation. We also found that, so similarly, that treatment wasn't offered to people during their rehabilitation. And people also said that they weren't provided with the opportunity to discuss the issue. So it would be interesting to kind of understand a little bit more, unpack that a little bit more to understand exactly what that was. So we just put out a general survey. We had some comments where people could embellish their answers a little bit more and talk a little bit more in depth to explain things. But I think we really need to understand a little bit more about why this is happening and you know, how we can find ways around it or solving it. Something interesting about the patient sort of, I guess, clinician relationship is people not feeling comfortable with approaching their clinician. But I guess, you know, it's an area that maybe not everybody feels comfortable with talking about straight away. So finding ways around that to make people feel more comfortable is something that we need to look at. One of the ways that we could maybe find to make people feel more comfortable in getting information about their own situation is an online resource. And there was quite a lot of support for having some kind of reliable online resource that people can access. And this is something that we've been talking to the Spinal Injuries Association about potentially having some kind of online resource available for people to use. Okay. So the main reason behind some of this work with the survey was to look at potentially doing further research into electrical stimulation treatments, because we'd had some experience where we'd seen some success from some case studies. So we really wanted to understand whether we could take this further, if this is something that people would be interested in potentially trying out as a treatment. The electrical stimulation directly to the genitals was found to be quite a popular option. So people said that, yes, definitely they would go for that. Not everybody said that, but there was some support for that. People saying, yes, definitely. Other people saying maybe. So perhaps something that they would consider, maybe with a bit more information. Abdominal electrical stimulation was also an area which people were interested in potentially trying out. So maybe, and also, yes, definitely, people reported. What was interesting was spinal stimulation, invasive spinal stimulation, so implanted stimulation. There was a lot of people there was a bit more, I guess, of a move to people not wanting to go down that path. But then with spinal stimulation, non-invasive, people were a little bit unsure. So they weren't sure either way. So again, probably more information needed, more research in that area. Okay, so just to summarize from me, we need to look at further research for alternative treatments, and there was support for that. There's support for research into electrical stimulation technologies. We identified a need for further information about available treatments, which we're going to talk to in a minute. Damian's going to talk about that now. And there was support for an online resource for sexual functioning, so developing something in that area. Thank you very much. Damian, would you like to go ahead?
Yeah, thanks very much, Tamsin. So I think your survey enables me to sort of follow that on quite nicely, because certainly some of those themes that have come out from that are really, really pertinent, and particularly with how people feel that they're not getting the information or advice that you would hope that they would do. So I think that is something that I will touch upon as well. So for this session, I'm not going to go into too much detail about the anatomy and physiology side of things, because not that it's not important, but I think talking about some of the treatments is probably more relevant. But I will touch on some of the anatomy, physiology, just because there is quite a distinct difference when it comes to spinal cord injury, Cordra-Quina syndrome, and the different presentations, which will enable me to be able to give the right advice to the right person. Next slide, please. So I'm just going to leave that up there for a moment, and hopefully you'll get an idea of why it is that I put this slide together. From my point of view, I think talking about sexual function, for me, it's no different about talking about every other aspect of somebody's the impact of spinal cord injury, but it is still an area that isn't always spoken about, and that certainly was proven with the results of the survey that was carried out. So it is often that elephant in the room that people are quite happy to talk about all the other aspects, but sexual function is just as important. So next slide, please. So it goes without saying that if somebody has a spinal cord injury, Cordra-Quina syndrome, it is a major life-changing trauma. For most people, they can identify with their life before spinal cord injury, so they know what their life was like before, and then it's a massive task to try and come to terms with their new life. And just some of these bullet points that I've got that you can see on your screen there, just to give you an idea of what the process might be if somebody has a spinal cord injury, and if they go into a specialist center, what's actually happening to them. Often one of the first things that will happen is that they'll be stripped off completely naked, body everything becomes very abnormal. Dignity flies out the window. The reason that patient's stripped off naked is because often they're on bed rest. It's easier to be able to monitor them, look at that, check their skin, make sure that they're kept in spinal alignment to help preserve the spinal cord as much as possible. But as I say, dignity sort of flies out the window. All of a sudden, there's this massive loss of identity, that person doesn't feel like the person that they were before they had their spinal cord injury. The body becomes public property. Often they are reliant on other healthcare professionals to do the things that they took for granted pre-injury, or those that can be more independent as they're sort of learning how to come to terms with their injury. Just everyday tasks can take that much longer, getting themselves washed, dressed, and that goes hand in hand with tiredness as well. So if you imagine the amount of effort that we take for granted, hop out of bed, jump through the shower, get dressed, and we're ready to go. The amount of effort it might take for somebody with a spinal cord injury, the tiredness that goes with that, possibly sexual function might not be at the forefront of their minds at that point, because they're probably just absolutely exhausted just from getting up in the morning. But that can change, and I think with the right support, we can get them more into that mindset that we want to try and normalize them as much as possible. But spinal cord injury, it does affect all the body systems. It does affect the bladder, it does affect the bowels, it does affect people's tolerance to pressure. So their risk of pressure ulcers is increased. It could affect their respiratory function. It affects everything, but I put there, it does include sexual function. And this should be talked about on the same level as everything else that we're talking about. When we're trying to empower those patients to become experts in their own condition, I think if somebody comes through a specialist center or even through a major trauma center, they're not experts in spinal cord injury. Why should they be? What we want to try and do is give them the knowledge to be able to direct their own care, to understand their own condition. And that includes everything. They should be just as aware of the impact of their spinal cord injury, how that impacts on their sexual function as well. And it's not just sexual function. Often we talk about sexual function and we talk about sexuality as well. We're living in a much more diverse society. And certainly, when I first joined the spinal unit in Salisbury back in 1996, I was there for 25 years as a clinical nurse specialist. Often sexual function was sort of fairly black and white. Generally, we would talk about heterosexual sex, but nowadays, we have to be more aware. We have to be very aware of that individual's sexuality, their sexual preference, how they identify, because it's not just one rule fits each person. We have to treat that person holistically, like we would do with everything else that we're talking to them about. And the same goes for sexual function, understanding that individual, what's important to them, so we can make sure that they have the right advice and the right information. The next few slides, we're just going to talk about sexual function following spinal cord injury, but also Cauda-Equina syndrome. And on the next slide, I'll just explain what the differences are, and just anatomically, just what some of the key areas are that make it more important for myself to be able to know what somebody's presentation will be, what their impact, their personal impact of their spinal cord injury, how that will affect them. So, and I will keep this as sort of as brief and sort of straightforward as possible, but the spinal cord is basically an extension of the brain, and it forms the central nervous system. So it helps us to control pretty much everything that we do, things that we can control, things that we don't control. And when I say things that we don't control, things like our heart rate, our blood pressure, the way that we regulate our body temperature. But it also helps, us to control the things that we have got control over. So, our ability to walk, our ability to be able to control our bladder and our bowel function. But when you have a spinal cord injury, that the spinal cord is that conduit for messages to travel backwards and forwards, from the affected area to the brain. But if you have a spinal cord injury, often those messages get blocked. They might be completely blocked, they might be partially blocked, depending on the degree of damage to the spinal cord or the Cauda-Equina. But just looking at that diagram, the spinal cord sort of ends at sort of the thoracic lumbar area, so around that sort of T12 L1 level. And I'm sort of very aware that I'm using terminology that people may not be familiar with, but very, very simply, you have the cervical spinal nerves and the thoracic spinal nerves. Where the thoracic spinal nerves end, you've got an area called the conus medullaris, which is the reflex center of the spinal cord. And this is quite a key area when it comes to how somebody may present, when they've got this type of nerve damage. Because if people damage their cervical or their thoracic nerves, they would generally present in a particular way. where these reflexes will still be present. And on the next slide in a moment, I'll just give you an example of what these reflexes are. But if the reflexes are present, then that can be used to that individual's advantage for all sorts of things, particularly with the bladder, the bowels, and sexual function, because those nerves that control bladder function, bowel function, and sexual function, they're the same group of nerves, and they're the sacral nerves S2, 3, and 4. So as you can see where the arrow is, that's right at the very bottom there. But below that conus medullaris, you've got the cauda equina. And the cauda equina, the cauda equina is Latin for horse's tail. So it gives you an idea of, visually what you're actually looking at, because the spinal cord itself above that is all quite neat and compact. Those nerve fibers are nicely bundled together. But below that conus medullaris into the cauda equina, those nerve roots start to fan out like a horse's tail. But as you can see where those sacral nerves are, it doesn't matter whether somebody has a cervical spinal cord injury, a thoracic or lumbar injury, chances are they're going to have some bladder, bowel, and sexual dysfunction, because those nerves are right at the base. Any sort of damaged area, above that, those messages are going to have trouble, traveling backwards and forwards. So I think we can safely say that pretty much most people with a spinal cord injury with cauda equina syndrome, they are going to have some bladder, bowel, and sexual dysfunction because of, the location of where those nerve roots are. So just to give you an idea of what a reflex is, that conus medullaris, that reflex center, a reflex is basically, you have a sensory nerve that picks up a stimulus. So that can be, a physical stimulus, a sensory stimulus, and it basically fires off to the spinal cord, crosses over an intermediary neuron, and then fires off a motor neuron to cause a muscle contraction. So that's a reflex. And just to give you some sort of context, you've probably seen, if you go into a GP practice and the GP, if he says, right, cross your legs, they tap you under the knee with a patella hammer, and then the leg just flicks out. That's a reflex. Those messages are just traveling to the spinal cord and bouncing straight back from the spinal cord. They're not traveling up the spinal cord to the brain, so there's no cognitive control over it. It's a reflex. Another example of a reflex is if you were to touch something hot on the stove, that sensory input from that hot object fires off to the spinal cord and bounces straight back to cause the muscle to contract, which removes your hand away from that hot object. It's a reflex. You have no control over that. But you can use that to your advantage when you're talking about sexual function. And we tend to break it down into two different ways. So how people achieve an erection, you can break it down to a reflexogenic erection, which is a reflex. So the diagram sort of on the left-hand side there is just an indication of somebody with a catheter going in through the penis into the bladder. Just that physical stimulation of having a catheter in the penis might be enough to trigger a reflex erection. So that patient may not have any control over it, but they can still get an erection. But just to bear in mind, these are the patients that generally have a spinal cord injury above that conus medullaris, that reflex center, where their reflexes are more likely to be intact. And the little cartoon just on the right-hand side, where, the doctor doesn't want you getting too excited, so I'll be giving you your bed bath today. Just that physical stimulation of, washing around the genital area might be enough to cause a reflex erection. It's very, very important that, as a healthcare professional that's providing that care to the patient, that they're explaining what's actually happening, because I've come across many patients that are quite embarrassed because maybe, back in the day, it was me that was helping them have a wash in the morning. And if they get an erection, you can just see that thought process that they're thinking, does he think that I'm attracted to him? I've got a duty of care to be able to explain to him, because, if I'm giving you a wash, you may get an erection, or if you do get an erection, it's a reflex response. And I don't want them to get embarrassed, but equally, I think it's very important for healthcare professionals to understand that as well. So it takes away some of the embarrassment for them, that they understand what's actually happening. So I mentioned about a reflex erection. So that is just the physical stimulation that's triggering that reflex. But there's also another way that people will achieve an erection. And this is all irrespective of spinal cord injury as well. But we refer to it as a psychogenic erection. So this is where you have those erotic thoughts, and it's having those thoughts that can trigger that erection as well, or to help provide an erection for that patient. So that there are those two different ways that somebody may achieve an erection, and you can use them to your advantage. I think the reflexogenic erections, where it's triggered by physical stimulation, is probably sort of more easier to assist in getting an erection, whereas the psychogenic erection, it's a bit more reliant on sort of maintaining that thought process. I think I'm looking at the time thinking it's 7:10 and I haven't had my dinner yet. If somebody starts having those, they sort of get off track, and they can sort of very quickly lose that psychogenic erection. So it takes a bit more concentration to be in that zone, if you like. But I think, having that understanding that, people can achieve erections in various different ways, it's very important for the patient to understand that as well. And I think if the patient understands that, then, that gives us a bit more sort of grounding as far as, what the options are for them. But the psychogenic erection, sort of being in that moment psychologically, can be very, very difficult, because spinal cord injury throws all sorts of other challenges to the patient as well, which I'll explain in the next slide, if you wouldn't mind, please, Tamsin. So I think, this is very well documented, that if you were to give somebody with a spinal cord injury a choice, and the choice would be, we'll either give you bladder and bowel function or the ability to walk. You can't have both. You must choose one. What would you choose? And every single time, pretty much without a doubt, that patient will say, I'm not worried about not being able to walk, but to be able to control my bladder and bowels will make my life so much more tolerable. Because you can argue that somebody with a spinal cord injury is doubly incontinent. I would argue that with the right interventions, you can help to make that patient continent. But there is still that fear, that anxiety at the back of their mind, that maybe their bladder or their bowels might open at a point that they don't want it to. So as I put up there, accidents, they might be unavoidable, but they're really not common. And I think, the timing of sexual activity around bladder and bowel routines gives a lot more confidence that it's not going to be an issue. And, certainly in my 27 years of experience of working with people with spinal cord injury, it is a very, very rare occurrence that people will have incontinence issues with their bladder or their bowels, while they're having sex. But it's certainly worth making that patient aware that you can take away some of that anxiety by creating, or having a very good routine. And that's where us as healthcare professionals can try and identify what the best routine for that patient might be, to sort of minimize an event like that. So I guess the most important thing, when I've given talks to inpatients before at Salisbury Spinal Centre, I can go through the anatomy, the physiology, but at the end of the day, most of the patients, all they want to know is, can I get an erection? Yes, you probably can. Okay, well, what will help me to get an erection or to be able to maintain an erection? Those tend to be the key points for those patients. Next slide, please. So this is where, I would talk to the patients about, the different treatments that are available to them. And I think, treatments have evolved. Medications have evolved as well. Whenever I'm talking to patients, I think most patients are aware of Viagra. It was, pretty much the first medication of its type to come out onto the market. And it can be very, very effective, for patients that, whether their reflexes are intact or they're not. I think those that still have their reflexes intact will possibly have a better outcome by using, these medications, but it's still worth trying, even those that have Cauda-Equina syndrome, to try these medications as well, because there are different degrees of how, the nerve damage would impact on that individual. So unless you try it, you're not really going to know whether it's going to be effective or not. But certainly what I found over the years is that people might take the medication and it might not necessarily be effective for them, but I'd probably be asking the question, are you taking it correctly? It's not just a matter of you take that tablet and then everything starts to happen. Certainly with medications like Viagra, it must be taken on an empty stomach, nothing to eat or drink an hour before or after you take it. So it takes away a bit of the spontaneity, if you like. So things do have to be planned to a degree. But, the medications have evolved, and things like Cialis, Levitra, you can eat and drink with them. They do stay in the system that much longer as well. I think Viagra has sort of an approximate shelf life of sort of 8 to 12 hours, which when I explain this to a patient, I've been asked the question, so does that mean that I'll have an erection for 8 to 12 hours? It's like, no. The medication is in your system. So it will enable you to be able to achieve a better erection and maintain it while that medication's in your system. And it's the same with the Levitra, Cialis, but that does stay in the system for a fair while longer, possibly 24, 36 hours, maybe even a tiny bit longer than that. So it does enable that person to be a bit more spontaneous, that you don't have to necessarily plan around it. But the way that these medications work, they enable, part of the penis, the corpus cavernosum, to be more engorged with blood. So, to stimulate the blood supply to the key area to enable an erection. And it isn't, as I've mentioned, just a case of you take the tablet and then everything starts to happen. These medications, they do still rely on physical stimulation as well. And it's little aspects like this that are very important to explain to the patient. So, they're not going to end up taking the medication and feeling that it's not working for them. But also as well, the medications, they come in various doses. So for example, Viagra, it comes in 25 milligrams, 50 milligrams, 100 milligrams. Quite often clinicians, they'll start that patient on a lower dose because the lower dose might work quite effectively for that patient. But if it doesn't, then you still got scope to increase it as well. But from my experience, patients, they might have been given a lower dose, and it's not worked. And then they've just thought, well, I've tried that medication, it hasn't worked, and then feel like giving up on it. But it's not until you actually speak to them and say, well, what dose were you taking? Well, I was taking 25 milligrams. Well, you realize that you can increase the dose. They're not always told, or, did you take it on an empty stomach? Oh, no, well, nobody told me about that. I think it always surprises me to a degree, if I did a medication round, that you'd be handing out these tablets, the patients will just take them. You could be giving them anything, not that I ever would, but, often people don't always question what it is they're given. They wouldn't always question, how to take the Viagra, but maybe they're not told either. So as healthcare professionals, it's very important that, if we're suggesting any sort of treatments, we are explaining, how they work, how they work to their optimum effect. So the tablets are probably the most popular form of treatment for erectile dysfunction. On the bottom right-hand side, where you can see that penile injection, this is one called Cavaject, where certainly when I've spoken to patients at the spinal unit, this is the one that sort of tends to make their eyes water a little bit, because just the thought of, putting an injection into the penis can be quite daunting. But it is another option, and again, it can work quite well, for various individuals, and it works in a similar way that it encourages the blood supply to the penis. But I guess just one word of warning, if you like, or just some note of caution, certainly with the medications, is that the way that they work, by helping to dilate those blood vessels, they work in a similar way to other medications that a patient might be taking. So if there's a patient that's at risk of a condition called autonomic dysreflexia, which is a unique condition to spinal cord injury, and it's the body's way of identifying whether there's any sort of pain or discomfort below the level of the spinal cord injury, which causes the blood pressure to rise. The emergency medication, which is often medications like glycerol trinitrate spray or nifedipine capsules, the way that they work, they dilate the blood vessels to reduce the blood pressure. So these medications, they do work in a similar way. So again, it's just another note of caution that if we're talking to patients about the treatment options, if we're talking about Viagra or Cialis or the other tablets, that they are aware that if they're at risk of autonomic dysreflexia, if they do need to take that emergency medication, that they just need to be very, very cautious about that potential drop in their blood pressure. Next slide, please. So, there are various different treatments for erectile dysfunction. And I think, the use of a vacuum pump, is a treatment that's been around for a long, long time. Essentially what you're doing is, the vacuum pump goes over the penis and you're creating a vacuum and, encouraging the blood supply to the penis. And this can work effectively for, any level of spinal cord injury or cauda equina. But often for those patients with cauda equina, where there often is no reflex to stimulate, these are patients that often we would suggest have what we call a flaccid paralysis. So they might not get that reflex erection. So using something like a vacuum pump is, a potential option for them. So once they've used the vacuum pump and, you've created that vacuum to encourage the blood supply to the penis, to stop the blood from draining back into the body, you use these restrictor rings, which just cause, a bit of sort of mild compression around the base of the penis to stop the blood flow, from traveling back. And we all come in different shapes and sizes. The restrictor rings come in different sizes as well. It is very, very important that, that patient is given advice to use the right size restrictor ring, because if it's too big, it's not going to serve its purpose. If it's too tight, it could cause additional trauma. But, it's very easy to get hold of vacuum pumps online. A lot of the equipment that patients can access, they can just buy online, and perhaps without the right sort of knowledge about the safety and the efficacy of its use. Next slide, please. So I don't want to sort of tread on Neil's toes too much, so I'm just going to mention this very, very briefly. And also partly because it's a technology that people don't generally see. It's not very widely offered. And if you look at this, the picture on the left-hand side, with that control box, and also the picture of the patient that's using this system, and I will explain just a little bit about what it entails. Even the picture looks quite old because it is quite an old technology. And there are a couple of centres, within the country now that are revisiting this type of technology, and probably in a more refined way as well. But basically what this is, this sacral anterior root stimulator, or SARSI for short, it's an electronic implanted device that is implanted under the skin, and you've got these electrodes that are connected to the sacral nerve roots. So those sacral nerve roots, as I mentioned, that S2, 3, and 4, these sacral nerve roots that can control bladder function and bowel function and sexual function. This implanted device, the idea is that you can artificially trigger, fire off those nerve roots to cause, the contraction of the bladder to empty, to trigger a reflex erection, to get the bowels moving. And what you have is this external transmitter that's placed over the implant, and then it's a matter of just pushing the button. So, I can't remember offhand, which button causes which reaction, but say for example, number 1 might cause the bladder to contract, number 2 might cause the peristalsis of the bowels to start to move, number 3 might trigger an erection. So it's very important that you do push the right button at the right time to get the desired effect. But this is a technology that it is available. It's not available generally to new patients, because the way that this process works is that, basically you are causing permanent disruption to those sacral nerve roots. So once this sacral anterior root stimulator is in place, there is no potential then. If there is the potential for nerve recovery, you pretty much damaged that by using this implanted device. So there is a rough rule of thumb that if somebody has the potential for neurological improvement, for those nerves to recover to a degree, often you will see that within the first 6 months, quite more significantly, but certainly within the first 2 years as well. So I would argue that this shouldn't really be given as an option to somebody if they're within the first 2 years of having a spinal cord injury, if they have got that potential for that nerve recovery. But, like I say, there are a couple of centres that are revisiting this technology in a more refined way. So this might become a more widely available option in due course. Excuse me. Next slide, please, Tamsin. So I think it's worth just talking a little about fertility, because when I first joined the spinal unit back in 1996, I think what we understood then is quite different to what we understand now. And I saw patients that literally had come through the door at the spinal center, trying to take on board everything that they're being told about, the degree of their spinal cord damage. And one of the questions that they might get faced with is, on top of that, because you've got a spinal cord injury, the chances of you having children will be greatly diminished. So to give you the best opportunity in the future, can we take a sperm sample from you and we'll freeze it, for future use? Often that decision had to be made pretty quickly, because the thought back then was that, the sperm levels would just drop to such a low point that, the chances of them be able to, have children, with sort of viable sperm would be very, very slim. But we now know that, you can artificially stimulate ejaculation, which in turn will hopefully, bring up the sperm levels to a much healthier degree. And at the end of the day, you just need one viable sperm to be able to fertilize an egg. But, you can increase, the success rate by using things that can artificially trigger not just an erection, but ejaculation as well. And the pictures on the right-hand side are just 2 examples of piece of equipment that are available. So the one at the top right is called a Ferticare vibrator. And, certainly when I've been teaching patients previously, when I take this out of the box and it's probably about, I don't know, about 10 inches long, the look on the patient's face, and, I've had patients say, well, where do you stick that? Well, you don't stick it anywhere. It's got a vibrating plate on the end of it, that vibrates at a particular frequency, which can be adjusted. And that vibrating plate goes against the glands of the penis. So it can help artificially stimulate an erection, but it can also artificially stimulate ejaculation as well. And the picture on the bottom is a similar system called Vibrect, which has got two of these vibrating plates, which just very gently sort of, when I say clamp around the glands to the penis, but go in contact with the glands of the penis and cause a similar effect. It's just two different companies, but a similar technology. And patients that are under the care of spinal centres, I can only speak for Salisbury, because that's where I came from. That patients do have the opportunity to be able to try some of these treatments to see whether they are effective for them. And that they are fairly expensive pieces of equipment. And I think, off the top of my head, I think the Ferticare vibrator is about £600-700 or thereabouts. But there are other charities that have provided funding for pieces of equipment like this, because it might not necessarily be funded by the NHS. But for some people, it is an effective adjunct to the other treatments that they might be using. Next slide, please, Tamsin. And again, I won't touch on this a great deal, because I think this might be covered to a certain degree with Neil. But it's there are other ways to support fertility, by using things like an electroejaculator, which I'm not entirely sure of the history behind how these were developed, but I think my sort of loose understanding is that this technology was developed for other animal species that are on the verge of extinction, so creatures like pandas, to be able to artificially help them to ejaculate, to be able to inseminate other pandas, to try and build up their population. But basically what this electrostimulator does is artificially cause that reflex ejaculation. And just one note worth mentioning is that patients with a spinal cord injury, they don't always ejaculate in what I would say the normal way, so ejaculating out through the penis. Some patients with a spinal cord injury might experience what we call a retrograde ejaculation, where the semen sort of passes up into the bladder. So that patient, they might get the experience of orgasm, they may not get the experience of orgasm. Often the majority of patients with a spinal cord injury probably won't ejaculate in a normal way, but if they're not planning on having children, they're of an age where their partner is of a childbearing age, the advice would always be use contraception in a regular way, because there will always be those unexpected pregnancies, and you can't just solely think, well, chances are I'm not going to be able to ejaculate, so I don't need to worry about contraception. You absolutely do, if you're not planning on having children. But it's just a note worth mentioning that if somebody does experience a retrograde ejaculation, they might not necessarily be aware that it's happened, but they may notice that their urine looks different. But I guess just another point to mention as well, and I did sort of touch on the fact about autonomic dysreflexia, which is unique to spinal cord injury, and it's the body's way of telling that there's some stimulus, some discomfort, below the level of their spinal cord injury. But orgasm can be a trigger for autonomic dysreflexia as well. And because autonomic dysreflexia is a life-threatening condition, and I don't want to sort of sound dramatic, but it is potentially fatal. But the caveat is that if it's well managed, lots of patients very rarely experience autonomic dysreflexia because it can be managed. But I guess the important point to make is that it is the body's response to this stimulus, but at the point of orgasm, which for men just literally lasts for a few seconds, it's not really something to be overly concerned about. But again, it's just something else to make that patient aware of, so that, you know, they are as informed as they can be about the impact of their spinal cord injury and how it affects them as an individual. And final slide, please, Tamsin. So that's where I'm going to leave it for now, unless anybody does have any questions at all. But hopefully that's just given you, you know, a very, very brief snapshot of what some of the treatment options are, but also the importance of actually discussing sexual function with somebody with a spinal cord injury and with cauda equina, you know, to try and normalize that conversation, that it should be talked about in the same way that every other aspect of the impact of a spinal cord injury is. So thank you very much.
Okay, thank you, Damian, for this nice overview. We have a remark in the chat, or the Q&A, I must say. It's about somebody, and it's related to what you're saying about discussing things or not discussing. This person was struggling to get a normal erection with a couple of tablets that he was given, and he was not given really advice or information, just giving the tablets. So struggling. Do you know about it? I mean, have you any experience with this kind of treatment, or lack of treatment, or lack of discussion?
I have, yeah. So I can only say what patients have told me, rather than, you know, anything that I've actually observed in my time at the spinal unit. But and it's not just you know, these are patients across the whole of the country, not just from where, you know, I've worked. But, you know, patients have said that they've just been given the tablets, and it's not. It might be by their spinal consultant, it might be by their GP, but, you know, here's some tablets, these should help, but not being given the advice about how to take them effectively. And, you know, often that's where, you know, patients that do try them, and if they don't work, then, you know, they're not, they don't have the confidence that it is going to work for them. Whereas, you know,
what can you recommend in this situation, or in these situations?
So I think, you know, firstly, they could go back to their GP. You know, often, you know, if the GP feels that it's not an area that perhaps they feel confident to discuss, the advice that I would give is to suggest to the GP they could either refer, you know, to a specialist spinal consultant, or they could refer to a urologist as well. Urologists often are very knowledgeable about erectile dysfunction, partly because it is those same sacral nerves that affect you know, bladder control, that affect erectile function as well. So I've certainly referred many patients to urologists for that type of advice. But I think, you know, in the context of spinal cord injury, is, yeah, where do you go to in the first instance? You know, the Spinal Injuries Association, you know, people can come to us for advice, and then we can direct them accordingly. If they are under the care of a specialist spinal centre, they could go to their outpatient department, where the staff there will be able to direct them as well.
Right. Okay. Thank you. Yeah, I still think it's going to remain quite a problematic where to go to and how to discuss it and get to the right information from the right person. But we have to move on to the next presentation. Tamsin, you're on for abdominal stimulation.
Thank you very much, Thomas, and thanks, Damian, for a really interesting overview of the area. Perhaps we could put just the contact details for the support line for the Spinal Injuries Association into that to answer that question. So you could type that in, and that person could then get in contact with the Spinal Injuries Association to have a chat if other avenues they've tried hasn't worked.
Yeah, absolutely. Yeah, I'll pop that into the chat box.
Brilliant, thanks. Okay, so I'm going to talk a little bit about abdominal electrical stimulation to improve sexual functioning, just very early days research that we've looked at. So If you'd like to get a more in-depth kind of look at this area, there's a publication in Spinal Cord Series and Cases. It's open access, so it's free full text available if anybody wants to read a little bit more in depth about some of the work I'll be talking about. So what is abdominal electrical stimulation? So ABFES uses small electrical impulses to activate weak or paralyzed muscles by exciting the nerves that connect to the muscles. We use self-adhesive patches or called electrodes, which are placed on the skin. So here's the typical setup, which is used for abdominal electrical stimulation that we use. There are other types of setups used for this similar sort of area, but this is the most common one that's kind of used in this area. So the background to how I got involved in this area came from doing work with bowel management. I'm currently doing a clinical trial called the Bowman Study, which is funded by the Inspire Foundation. And it's an NIHR portfolio study, and we hope to have some results in the next couple of years or so. So initially we started looking at the area of bowel management and using abdominal FES in this area. Of course, when you do any research or you do any treatments with the bowel, because of the proximity between the bowel, the bladder, and sexual functioning all around this sort of pelvic kind of area, there's a likely effect that you'll have some influence on the other areas. So during the Bowman study, we're looking at outcome measures to look at bladder and sexual functioning, although the bowel is the predominant focus of this work. Abdominal FES has also been used for respiratory functioning. If you're interested in this area, there's a good systematic review by McCarthy et al. Published back in 2016 in Spinal Cord, where you can look at this more in depth. So it's kind of an area which is quite an interesting area to do further work in. So I'm just going to describe today a case study that we had, which kind of got me involved in looking at this area. So a 74-year-old man with a spinal cord injury with a C5, C6 lesion, incomplete spinal cord injury, was referred for abdominal electrical stimulation for his bowel management. So he's put on a course of a 6-week treatment intervention to use the abdominal FES using the same electrode setup that I showed you in the previous picture, for 15 to 30 minutes twice a day, more or less every day, but maybe not doing every single day. So at the end of the 6-week sort of trial, we had a semi-structured interview to discuss the findings and how he got on with using the stimulator. And he reported having some unexpected improvements in the strength and duration of his erectile functioning after using the abdominal FES, roundabout after using it for about 3 weeks. At the time, he was not taking any medications for sexual functioning, and he also reported not using, so this is important for later on when we look at the cause, but he reported not using electrical stimulation during sexual activity. So this suggested it wasn't sort of a stimulus result of the electrical stimulation helping to activate and improve his sexual functioning during the time. At all occasions, he used the electrical stimulation at a different time to when he was engaging in sexual activity. Prior to reporting these improvements, he was able to have something of erectile functioning, but he was unable to maintain the erection for very long. He reported there was also an improved aesthetic appearance of the abdominal area, so helped to improve the muscles around that area, possibly also reducing some of the bloating because he reported improvements in his bowel management, so reduction in his overall bowel function. He also reported improvements in self-esteem, in his bladder functioning, and as I said before, abdominal strength. So what was going on here, I suppose, is important to sort of think about it. Just threw up a lot of questions. Was this just an isolated case? What was the electrode placement? When was the electrical stimulation used? So we already know he didn't use the electrical stimulation, importantly, during the sexual activity. So it wasn't a sensory sort of stimulus. In terms of the electrode placement, which is the other question to ask, we asked him where he put the electrodes. And he, so if you remember, the picture showed the general electrode placement, which we would normally use. And we found he was using the electrodes, the lower 2 electrodes from the picture, if you remember, and they were slightly lower down than we would usually have placed them. And that may have had some activation of certain areas that may have helped to improve his sexual functioning in terms of innervation of nerves that wouldn't have otherwise have been implicated. The next question would be whether it was an isolated case or not. Were other people experiencing this from using abdominal FES for bowel management? So from getting this information from him, we were able to start to ask other people and to start to explore it, as well as designing a research study for the future. And we asked somebody else who was using it, who also had a spinal cord injury, a complete spinal cord injury, and he'd also reported some improvements in his sexual functioning, specifically his ejaculatory functioning. And other people using it with multiple sclerosis, who were male, reported improvements in their sexual functioning. So that was quite interesting. But we didn't see an improvement in the experiences for women, or at least for the ones we asked. Again, this is very limited because we only had a small sample of just a few people who are using the electrical stimulation for bowel management at the time. What's really interesting in terms of the potential improvements that are going on and the causes of them is that for people who are non-neurological, who don't have a spinal cord injury, there's good evidence to suggest that using cardio exercises can help to improve erectile functioning. So potentially there was some influence from improving the vascularization around the abdominal area. Potentially that may have contributed to improving erectile functioning for these people who reported it. Also, there's the improvement in body image and self-esteem, which our 74-year-old reported was really important to him. Another really interesting area to look at is the potential of the innervation of the nerves involved, either directly or through the psychogenic pathway. So if you remember when Damian was talking about the different possibilities of how an erection can be produced, there's a couple of different pathways. So maybe we're able to tap into an alternative pathway through using this, this abdominal FES. Okay. So just very quickly, I'm going to talk about another use of abdominal FES, and that's combined with the vibratory stimulation. So in Damian's talk, he showed a picture of the different types of vibratory stimulators that are available. And there's a couple of interesting case studies which looked at combining that with ABFES. So a 37-year-old man with a T3 complete spinal cord injury had reflex erections easily, but these were poorly maintained without continuous stimulation. So he experimented one day combining vibratory stimulation, the VBS, with the ABFES, and at the same time, and found that that facilitated ejaculation. So he spoke to the researchers about it, and he said, and they said, well, let's see how many trials you can score with and without. So with VBS alone, with the vibratory stimulation, 4 out of 30 trials were successful. But when combining it with the abdominal FES, 31 out of 34 trials were successful for ejaculatory functioning, which was really interesting to see that difference. This suggests that maybe in the future, combining different types of treatments, mixing and matching things, might provide an improved outcome in some situations. The 2 further case studies with similar results, which found that combining the abdominal FES with the vibratory stimulation was more effective. It might be the case that combining these type of technologies with certain types of medication might also be helpful in the future. Okay, so just to conclude, there's very early days with this sort of research. Larger studies are required to explore this area further, and the current study, the Bauman study, which I've mentioned, is including measures on sexual functioning, and we're looking at potentially writing some more studies to look at this area further. Thank you. So I think I'll pass straight on to Neil, and then if there are any questions, we can take them at the end. Okay.
Cool. Thank you, Tamsin. Thank you, Damian. So I'm Neil. I'm one of the doctors working down in Poole. Having worked with Tamsin in the past, I'm just going to go through a case report relating to male sexual dysfunction. So go on the next slide, please. So I think Damian's covered this really well, but as we all know, sexual functioning is really important for quality of life, of course, across people, both in and not in the spinal cord population. And the prevalence of sexual dysfunction is actually really high amongst the spinal cord injury population, with a greater prevalence than both than bowel or bladder dysfunction. And as Damian's talked about already, ejaculation is the physiological culmination of the male sexual cycle. Next slide, please. So why would we want to pursue research in this area? Well, if you survey the spinal cord population, it's very clear that sexual functioning is really important for feeling an intimate part of a relationship. And despite sort of theories of Darwinian reproduction, actually sexual functioning for fertility actually is a sort of a low priority amongst that group. So actually really reinforces the need to look into the intimacy side for the general quality of life. Next slide, please. So going over what Damian's discussed already, so primarily penile vibratory stimulation is effective amongst the population with a injury level around about T10. As Damian mentioned briefly, electroejaculation is a process of effectively harvesting sperm, but that's physician-led, usually in an outpatient clinic. And that in itself comes with its own risks. It can sort of predispose to autonomic dysreflexia amongst those patients. Next slide, please. And again, so this just goes through the current management for erectile dysfunction. The phosphodiesterase inhibitors, which are your sildenafil group, have a reasonably good mechanism. However, they do experience a number of side effects, and especially something called tachyphylaxis, which is where through prolonged use they become less effective. And as Damian was discussing sort of from the urology side, this is very much the domain of urologists. When you talk about sort of the injectable medications, they were the predecessors for the oral medications, and something that they're very much familiar with prescribing and using. The vacuum erection devices, the sacral anterior root stimulators, and then more recently, as Tamsin's just mentioned, the use of functional electrical stimulation, initially through the use of either stimulating the pelvic floor muscles, or more recently through the use of abdominal wall muscles. Next slide, please. So we're going to discuss a case report. So this relates to a 46-year-old gentleman with a spinal cord injury at the level of T4. It's a complete injury at age A. And prior to the injury happened 8 years prior to what we're about to discuss. He describes that he's able to generate a psychogenic erection occasionally and a reflexogenic erection on demand, and that's through the use of tadalafil. He's able to maintain that erection for longer than 5 minutes. Reported that he used ABFES, the abdominal electrical stimulation, to improve his erectile function and to generate ejaculation. But described that despite being able to produce an erection they were unable to ejaculate or achieve orgasm with either manual stimulation or the penile vibratory stimulation. Next slide, please. So they've used an functional electrical stimulation device called the NeuroTrack MyoPlus. They've developed their own electrodes using 4mm conductive rubber tubing, and their diagram describes the layout that they've used. So they placed the anode around the base of the penis, which was shielded from the body, and the cathode was connected around the penis immediately below the glands and touching the frenulum. Next slide, please. So they've described that they used the device at home, and they reported their erectile functioning, ejaculatory function, and their orgasm using a self-reported diary. Their body position was supine, so laid on their back with their head raised by pillows. Initially, interestingly, we'll go on to other positions that they've attempted. and they started at a low power and gently increased it until they felt that an ejaculation was going to occur, or it had, or evidence that it had happened. If the ejaculation didn't occur within the first few minutes, it was stopped, and then after a 10-minute break was attempted again. Next slide, please. As you can see here, there are 6 different methods that are utilized, a variation of channel usage, and then later on a variation in their positioning, moving from their lying on the back supine position to kneeling, and then an addition or variation in their positioning of their anode and cathode. Next slide, please. So looking at the results, if we look at initially the selection of attempts using a single channel, we can see that although ejaculation was created or developed, stimulated in all groups, we can see that the sensation of orgasm was achieved only when the position was changed from supine to kneeling. Also see that they reported that the spasticity increased immediately after the ejaculation and dissipated later on. Take the next slide, please. And then when we look at sort of the side effect profile of using this, using the single channel at a higher frequency, or using dual channel predisposed to autonomic dysreflexia. Otherwise, or dysreflexia was seldom, wasn't reported in any of the other mechanism used. And we can see that using different positioning, so the kneeling position not only produced the sensation of orgasm, but also developed this at a much lower power required, and was more often successful on the first attempt, requiring minimal second attempts. Next slide, please. So why is this relevant? So the potential benefit of using fractional electrical stimulation to generate the sensation of ejaculation, so the sensation of orgasm, but also to generate ejaculation, using the settings toward lower power ranges, which reduce the risk of generating autonomic dysreflexia with a shorter refractory period between attempts. And I suppose most interestingly, really, as well, not only is the use of a different type of technology, but also the showing that the importance of variations in body positioning, which impacts on the ability to ejaculate, moving from the supine position to the kneeling position, and generating the sensation of orgasm. Next slide, please. And then spasticity and achieving ejaculation associated with that kneeling position. So I suppose moving on about whether or not using this device or this layout of electrodes with a larger sample size, and to give us a better idea of how that accounts for how the variation sits amongst different members of the spinal cord injury population and with different levels of injury and preference. Finally, where you go next with this area of research or interest, I suppose, patient public involvement is something Tamsin's been really involved with the Spinal Injury Association. And then I suppose, as Damian described earlier about, who does this sit under? I suppose it sits under the domain of both the spinal rehab consultants and also the urologists. And finally, another big area that is of equal importance in research is female neurogenic sexual dysfunction. And then the last slide, I'd just like to thank NE for their input with this project as well. That's me done.
Okay, I think that was a good discussion. I think we need to close. We ran out of time. We took already a little bit too much time of you. Some people need to move on, having dinner or other things to do tonight. So I would like to thank the speakers, Damian, Tamsin, and Neil for their presentations and the discussion. And I would like to thank Ken and Michael for their technical support to make this possible. And I would like to thank the audience for being here. Still, we haven't discussed everything. We didn't have enough time. It takes a lot more time. And so we will continue, and maybe in the next webinar, we will further discuss this topic. If you have any suggestions, please let us know. And hopefully we'll see you next time. Tamsin, is there
No.
anything else?
Just to add, just as a sort of for questions for people who are interested in participating in further research, or if anybody has any questions for me, Damian or Neil, we'll send out an email with some contact details to get in touch with lots of details. So if you're interested in research or getting in touch with the SIA or have any questions that you want to talk or discuss, I know it's not the easiest forum to talk online with a webinar that's being recorded. So we'll provide that shortly after the webinar. Thank you.
And just finally, just to say that I have provided the support line telephone number that went into the chat function and our online referral form. So if there are any queries, from today's webinar, by all means do get in touch with us that way.
All right. Well, thank you so much, everybody, and you all have a good evening.